A nation with a population of over 200 million people, with only 35,000 doctors. That is one doctor to 53,000 Nigerians. Healthcare allocation is 3.5% of the GDP, $5 per person per year. WHO recommends 5%. This explains why our healthcare system is the way it is. Patients are not being attended to, government hospitals are overcrowded, health workers are overwhelmed, private specialists are unaffordable. Something has to be done. To tackle these issues, Health for Nigeria believes the healthcare sector needs an inspired and well-motivated group of young leaders to canvass and act for excellence in the healthcare standards of Nigeria. Our team of healthcare professionals and leaders are committed to improving access to healthcare for all Nigerians, especially our children.
Can I check my sound? Do you hear me?
Nigeria, a nation with a population.
Good morning. Yes, we can hear you.
Thank you. Yesterday, one time it didn't work. So I'm like, oh, what a day for it not to work though. So good morning, everybody.
Good morning. Nice to have you.
All right. So I think we're just about hitting our starting time. So I'd just like to say good morning, good afternoon, everybody. Thank you for joining us for this awesome lecture. The short video showed, Health for Nigeria. We're an organization that's trying to foster healthcare and leadership in Nigeria. And we're using this platform as an opportunity to share some of what we're doing, as well as bring these opportunities to as many people as possible. So I'll introduce Dr. Akintade. He's our founder and pretty much the brains behind Health for Nigeria. He's a professor at the University of Maryland, and he's also a healthcare professional, practicing nurse in the ICU. I'm sorry, not the ICU, emergency care. Sorry, at the University of Maryland Hospital as well. So please welcome Dr. Akintade as he introduces Dr. Storr.
So good morning, everyone, and thank you for taking the time to join us this morning. I know we have people hopefully represented all over the world. I know we have some viewers from North America. We'll have some individuals joining us from the UK and also from Nigeria. We're really excited for this particular presentation because we understand how data and data collection, or just even the understanding of why we collect data, data collection and data management has not necessarily been an area of emphasis for us in Nigeria. So hopefully what we learn here today will not only transcend, but hopefully start to become a part of what we do very naturally. I'd like to recognize one of our board members, Mrs. Alero Aida Otobo, who's here also. She's also a fantastic mind and brains behind lots of work in the public sector. So hopefully, she can also chime in. I see the president of the National Association of School Nurses, Donna Mazek. It's nice to see you here also. But without taking any more time, our Health for Nigeria monthly lecture series basically is an opportunity to keep our Health for Nigeria nurses, to give them an opportunity for continuing education. And we recognize that at the same time, with a name like Health for Nigeria, the expectation is to be a platform to educate as many people as possible. So that's kind of where this came from. Our speaker today is very near and dear to me. So Dr. Carla Storr is the director of one of the University of Maryland School of Nursing's interprofessional research centers, the Center for Health Outcomes Research, and a professor in the Department of Family and Community Health. Dr. Storr earned her doctorate degree from Johns Hopkins Bloomberg School of Public Health and has a master's and 2 undergraduate degrees from the University of South Florida in Tampa. She's been a member of the University of Maryland School of Nursing faculty since 2008. She's very active in the PhD program, teaching measurement and methodology courses, and sits in many final dissertation committees. In 2015, she assumed the role of course director of one of the core graduate courses, Biostats for Evidence-Based Practice. She's passionate about mentoring and is also known for inserting practical examples with her courses that bring the concept being learned to life, while she also provides opportunities to expand one's skill set. Her research interest includes understanding the etiology, comorbidity, and symptom burden of mental health conditions and disorders, with a specific focus on substance abuse. She has also studied factors associated with care outcomes in nursing home and assisted living facilities. It brings me great pleasure to introduce Dr. Carla Storr, and many of us who have been part of any higher level education understand that sometimes there's difficulty involved, which presents as a rite of passage. My doctoral education was challenging for so many reasons. The one of the few shiny moments I had was in my class with Dr. Carla Storr. So not to put her age out there, but Dr. Carla Storr was also my measurements professor. She was very kind, very knowledgeable. And we've been colleagues for a few years now, and I've used her as a resource, for many things that I've done over the years. So thank you, Dr. Carla Storr. We welcome you, and you can take it away. So you can just tell us a little bit about yourself, and then you can start your presentation. Thank you.
Right. Well, thank you. And I get good afternoon to, I guess, the majority of people, and a few other people, maybe a good morning. Thank you for inviting me to come speak. I've been active with other groups. I think another faculty member is trying to help people in Uganda, if I remember, and stuff. To me, health, especially mental health, is a big international issue. So I also kind of support these kind of efforts. So let me see if I can host disabled participant screen sharing. I think I can't get my slides up.
You should be able to share your screen now, I believe.
Oh, now I can. Well, I think I can. All right. So hopefully, so everybody should see it now, kind of in a sense. So I was asked to talk about some kind of put together some kind of data talk. I'm not going to go a whole lot into analysis, although I'm going to give you a technique that hopefully after this you can start actually doing something with it. It's pretty straightforward, and yes, it has more sophisticated layers to learn it more in depth. But BIM, well, Dr. I call him BIM, whatever. Sorry.
You can just call me
We
BIM.
discussed how a project actually that's underway, how it might be a useful technique. So a goal is hopefully that you'll be able to not just learn new knowledge, but then turn around and start applying it shortly. So, all right, advance. Come on, page down. All right, page down doesn't work. Enter doesn't work. Any other suggestions, guys, of how to forward my slides?
You should have just complete control, and you should just give it a
I know. Oh, there. Okay.
transition slides.
Whatever I did. All right. So I'm going to be talking about issues more related to data quality. In a sense of these are more or less a review of the steps of what you need to think even before you even start your project or start thinking of the various components that you need to think about before you collect data. And so I kind of call them steps, because data quality is really important, because all processes are what, in the sense through healthcare, they have characteristics that can be measured, and then that leads to analysis, which hopefully your findings will lead to some kind of improvement or at least controlling of some kind of situation. The quality of the data is very important, as is the type of study design. And of course, you want to look at the consistency of the finding of important issues before you really start making those major decisions about making some kind of change in your system. One research finding doesn't mean you just totally change the whole way you do things. It does need to be repeated and make sure everything about the quality of the data and some of those features like reliability and validity, which I'm going to review in a couple minutes, are extremely important. So the bottom line is, you want to feel confident that the data you collect and are going to use is really a reflection of reality, and that you are assessing or measuring what you think it is. So my objectives are, first, to quickly describe the role of measurement. And then I'm going to go through the steps of measurement. Those are the couple things I had referred to. I'm going to compare a little bit statistical approach versus a visual approach so that you can assess changes over time. So I'm not going to go deep dive into statistics. I'm going to focus a little bit more on this visual approach, because you'll see it's very user-friendly. And that leads to me describing and illustrating to you the basics of what we call a run chart. So what is the role of measurement? It's really a critical part of testing, and if you want to make changes in healthcare, you need to measure something to evaluate if changes are happening. And quality measures help drive that improvement, because you have construct a consistent and accountable approach. Detecting changes and evaluating if it leads to improvement. Now realize sometimes your efforts may not lead to improvement, but at least you're monitoring it so that you can then maybe stop what you're doing and change tracks. Doing research or data collection, it doesn't have to be difficult or time consuming. The key is to pick the right measures as well as the analysis approach so that the team can see the results quickly. And you need to be confident that those variables that you're using, I'm going to harp on that, is a reflection of reality, and that you really are measuring what you think you are supposed to be capturing. So measurement involves picking some kind of concept that you're interested in. Let's say decreasing infection or whatever. How do you assess that? And when it moves to an analysis phase, you take this vague thing and you assign it a number, because you need those numbers to do your analysis. And with that, along with that, there's always some error within your measurement. Some of that error you can try to control, and some of that error you can't control. Somebody's visiting the clinic, you can't control their anxiety, and that being anxious might affect some of the results that they answer to you. Some of that you can't control. You try to make them feel as comfortable as possible, so you're trying to decrease that. But errors such as not having like your scale calibrated in the morning. So when you start taking weights of people, you know your scale is calibrated, and not that, whoa, everybody seems to be 5 pounds heavier today, because you forgot to calibrate your instrument. So those are examples of some errors. When we talk about measures, there's a notion of quantifying things, where we're actually trying to estimate the magnitude or the amount of something. And those are usually stable phenomena. And because we're able to estimate the amount, we can start describing like the distribution and start using other mathematical kind of functions. We can compare groups of people. We can compute averages, as well as measurement can contain a notion of a qualitative measures, which basically is assigning objects to categories that are mutually exclusive. And a lot of times those are dynamic and changing phenomena, but you're able to describe the process. So here's a little schematic of if you had a research idea of something you want to kind of analyze or whatever. You usually start with your problem and you have an objective. You pick your design, your sampling and whatever, but I'm going to be focusing more where I put this a blue box around here. This is not that measurement isn't a little bit in some of these other aspects as well, but the measurement piece that I'm talking today has a lot to do with what are you going to collect? Here we are talking about, are your measures going to be valid and reliable? As well as you need to start thinking about when you start collecting data about how am I going to analyze this? Because that if you want to use certain analytic tools, you have to have the right kind of measures to be able to use them. So we're talking about this part of the schema. So here's the first measurement step. We begin with basically, what is the purpose? Do you want to describe something? So are you monitoring something that's happening in your setting? Do you want to document how many people have immunizations or things like that? You want to, often we think that's common sense. It is a research kind of technique. Other times your purpose might be to classify people. You want to actually identify types or groups of things going on. It could also be a purpose of mapping, capturing the time and space, seeing trends. You can picture the map of the global maps. World Health Organization does those global maps of well, I'm a drug researcher, so I can see like, oh, where is the cannabis use the highest? You know, the maps of the world where they have the different color tones. That's what they're trying to do, capture time and place of where peaks of HIV or COVID maps would be an example of that. As well as thinking about the purpose, are you trying to do some kind of analysis? Is it a quality improvement project? Which is often like something that nurses can implement within their settings. They're trying to improve the quality of something, so they'll try a literature-based intervention to see if they can make a change to improve whatever aspect, decrease waiting time or whatever. As well as analysis is involved, yes, and people who are doing more research projects. As well as it's important for political dialogue, especially changing policies at that level. So also important at this step is the type of measures that we can talk about. These are three kind of types of measures taken from the quality improvement literature. They talk about process measures. It has to do with like what the provider does to maintain or improve health. And that can be for either healthy people or those who have a particular health condition. They typically reflect the accepted recommendations for clinical practice. So some examples would be, you're gonna monitor the percentage of students receiving preventive services, percentages of students with diabetes who have had their blood sugar tested and controlled. Maybe you want to monitor the percentages of students referred for malaria testing. Another, and a lot of people process measures are actually, let's say, the easiest, lowest hanging fruit, as we kind of say, to kind of go after. But another important kind of measure is an outcome measure, because that really reflects the impact of your healthcare service or the intervention on the health of the patients. So there you're actually studying other things, such as the percentage of students who eat fruit daily as a result of the dietary counseling. So the healthcare service is that, ooh, we provided dietary counseling, but I want to see the outcome of how many people are following that. Another example, the rate of surgical complications or hospital-acquired infections. The hospital gave some kind of service. You had, whether you had surgery or whatever, but oh, well, what follow-up kind of infections came out of that? Another example, average hemoglobin A1C level for population of patients with diabetes. Hopefully the healthcare service is treating that diabetic, but you want to judge the outcome at the for the people. How well are they maintaining their A1C level, as well as their structural measures, which that's a little bit more a sense of the healthcare provider's capacity or their system or their process. So that's like whether a healthcare organization are they using electronic medical records, or are they using medication order entry systems? Maybe we want to compare things on the number or proportion of board certified or care providers and ratio of providers to patients. So those are more at the, the upper, I guess, the administrative kind of level things. So whatever measure you pick, variables you want to pick, though, they should be important and something that can be improved on or that you can make change. You don't want to just study something that is stable, and the idea is you're studying it because you want to do an intervention or do a prevention effort. And that's where process measures tend to be easy, that you can act upon them and actually judge or see if the improvement is happening or not. However, in addition to just because they're easy to see that change, there should be an underlying thinking through that somewhere along that process measure should be linked to some kind of patient-centered outcome. Because outcome measures are actually significantly more important to the people in general, and they aren't as responsive to improvement initiatives. So you want to see changes in the process, which hopefully lead to changes in your outcome. So that was kind of the first step of when you're thinking what you want to study. The next thing is, okay, I need a conceptual definition, or there's usually some kind of theory behind what you want to do. So basically, you have to think through what do you want to measure and how are you going to define that? So often you can develop a preliminary definition and as well as review the literature to identify maybe examples of how other people have thought of measuring a certain concept. When you get your conceptual definition set, certain things are easier than others because they're a little bit more concrete. If you're looking for infection, well, I'm going to define infection as, wait, is there a temperature? Is there redness in the area? Is there pus? Is there an odor? Like, what are you going to define as, this is what I'm going to call an infection? Whereas that's where you go to the literature, because maybe other teams say, no, that's not an infection. This is. So you need to know for sure what you're studying is and how you want to define it. And then once you have that kind of theory, conceptual definition, you want to turn it into something what's operational, or, okay, now it's putting things to how am I going to do it? And start thinking of how those things can turn into a number, or perhaps you might need to make a scale. So You want some things are directly observable. So as I was pointing out, like, well, if I'm going after infection, maybe I need a collection of things to be able to define that by looking at the skin color, the swelling, the odor. Other kind of things you may want to study, like temperature. Some of those things require some kind of amplification or transformation. So usually they need some kind of, let's say, machine or technology device. It kind of goes through this black box that you use something, you put either blood in it, you attach it to the patient, and then out comes the result that you're going to use. But some of the things we want to measure are actually abstracts, things like depression, parenting skills, help seeking, or pain. We're going to rely on using questions. And so you probably all have seen scales. We ask a couple like depression. Do you feel sad today? Did you have trouble sleeping? Are you eating too much? Are you having trouble concentrating? You take the responses, this creates kind of a scale or a kind of a diagnostic kind of screener kind of thing. And from that, you kind of determine whether they meet the definition or yes or no. So it's important that that definition is focused, because if you aren't clear about your definition, you start bringing in other kind of things that may not actually, like if you take the infection example, if you start bringing in other things in there, like, okay, well, sensitive to touch. I mean, I guess if it's an open wound for infection, it would be sensitive. But if you start bringing in the wrong kind of things, you're not, it starts, you lose your focus. And after a while, what you're measuring, it kind of grows into some other thing. So you're no longer assessing what you thought you were. So a lot of times you can use tools that exist in identifying measures. You may need to do some creative mind, like mapping of ideas. In a sense, there's techniques to kind of develop tools. But if you're starting out, I highly recommend using tools and measures that already exist. They may need to be adapted for your circumstance, and especially I'm talking to an international crowd. I don't want anybody to assume I'm like, no, you can't just take this measure that we created in America just because, oh yes, what works over here may not work for you. You have different circumstances that might be accounted for. But if you have established tool, you can do things that are called like benchmarking, which basically means, can you compare then your results to what others obtained if you're using the exact same measure, the exact same procedure and things like that. So it's nice to have this opportunity to compare that, hey, we're like them or not. And you can get samples of tools that you can adapt or whatever for your own purpose. Be wary though, that some people have this label or a name on their measure, and it may not be, it sounds good. Oh, that's what I'm assessing. I'm going after depression. I can use this tool. It says it's a depression tool, but is it going after what you want? So you may find this measure that is good, but it may actually be measuring something different than you need, or it measures only part of what you want. So I'm picking on depression only because I'm more mental health, substance use orientated. So naturally my examples come from my expertise area, but I'm just pointing out, don't worry if you don't know these tools, but these are 4 depression measures. One of the CESD is more of a population or a public health kind of assessment for depression, whereas say things like the Beck is more of a clinical orientated measure. But you can see these are the number of items. They're okay, the GDS is 15, but all these other tools have all the same number of items. But if I'm interested in going after, let's say, the symptomatic kind of physical symptoms of depression, I might want to pick one tool than the other. For instance, the CESD, almost half, we have 9 items, are actually focusing on this emotional status. So if I'm going after something that's trying to capture a little bit more of the physical symptoms, the impairment that it's causing, I'm like, oh, they only have 2 physical symptoms and they may only have this one question about social function, like it's impairing them. They're not able to do their work or whatever. Maybe the CESD is not the best tool for me. Maybe something like this HRSD is. It has 8 items on physical symptoms. So that's what I mean by, just because the tool has a label that says it's what it is it matching what your definition, what you want to go after? So that's something to keep in mind. There's other aspects of measurements that think about the time element. If you're asking questions, what kind of time frame are you capturing? Are you capturing like this ever or lifetime? Or your question's more like, oh, did this happen to you in the last year or month or whatever? Are you planning to do longitudinal assessments? The tool you use to measure needs to be sensitive or able to capture changes. Some tools measure traits or something that doesn't change over time. So if you want to see how a trait of personality trait changes over time, you need the right kind of tool. Or stick with my depression sample. If you're trying to treat them for depression, you want a tool that will actually show improvement in it. So you want that responsiveness. Other things to think about before you select something to measure is these are more the utility, or is it practical to use? What are my resources? Do I have to pay for the tool? Sometimes tools some of the clinical tools especially, you have to pay a fee or whatever. Some of them need special training. How long does it take to administer? Like, do I have to pay for a room or whatever? How complicated is it going to be to score it? And also think from the side of the person taking this, whether it's a survey or you're doing more of a clinical kind of thing. How long is it going to take to complete? If you're doing this with a child, are they going to sit still for you a half an hour to ask like 101 questions? Now their parent might, but a 10-year-old probably maybe only have 5-10 minutes of their attention. So how long is this instrument? And so think of, there's also standardized instruments that were professionally developed that have extensive testing. And I'm pointing out promise measures because those are also actually even international. A lot of the promise measures are actually already translated into other languages as well. Promise measures are tools that, like for depression, instead of having a 20-item depression scale, they have figured out a way to, I can use three questions to get started. And depending on how people answer those 3 questions, you either ask more or it gets closer to finding what the score might be a lot quicker using fewer questions. That's a short description of that. So once you know how you're going to do it, you want to standardize the protocol of the steps to follow, because you always want to collect your measures as consistently, and anybody doing it should do it the same, because that will help minimize any kind of measurement error. And then we're going to start now thinking about the quality of data involves validity and reliability. Okay, so how good the measures quantify what you really want it to be is validity. And is it consistent? If I gave this person the same questionnaire tomorrow, will I get the same result? That has to do with reliability. Reliability basically means you're hoping that there's no random error coming in, that you'll get the same score each time. The validity means, does it measure what it's supposed to? And this graphic at the bottom, if this is your true value, the distribution of scores, A is showing the distribution. All the answers are around the true value. B is a report that's valid because it's capturing the true value, but this distribution is so big, it's not reliable. Like the range of scores is just so out of control. You can't feel confident with it. Whereas these examples on the right, C and D, they're not, whatever they're measuring, they're the C, the D, the red one, that's a very good measure of something. It's just not what you want it to be. But both of these aren't even measuring what you want. So this is kind of a nice graphic to think through how validity and reliability mean to your data. There are different types of reliability. We talked a little bit about that stability. So you may be familiar with like test, retest. So that's really just means, are the values similar on two different administration when you use the same participant? You may hear of doing a correlation coefficient to calculate it. You need to consider though the time interval. Some things just naturally will change. If you're studying certain things, depression, well, I'm trying to point out that certain things in adult, because you're already, you have full cognitive capability, measuring things between adults can longer time periods, but when you're measuring things among children, because they're changing rapidly, the time interval may not be allowed to be like 5 years later, because a child going from age 8 to 5 years later, there's a lot of changes versus an adult who's 40 going to 40 to 45. They're probably not going to change on certain kind of variables. So that's when you're picking a test, what this stability dimension of reliability means. There's also consistencies of rating, and that has to do with if you have multiple raters, no matter who asks this question or whoever is doing the observation, they should all be replaceable. And that you can do by training and quality control, that they don't start putting down results of other things they see. And it can also mean consistency of ratings by the same rater, but on different occasions. So it is just a sign of reliability. What are you turning on? Sorry, my phone is trying to talk to me. And when we use scales, we talk about internal consistency. That's a type of reliability, which means the questions on the scale, like my 20 depression questions, they should have some kind of intercorrelation. Every question is important because it's going after depression. So those instruments should have what are called a Cronbach's alpha of at least, we aim for 0.8, or for clinical purposes, actually a little higher. But it means the items hang together. You could keep adding questions to it. That usually helps you measure the concept better. But remember, your tool's getting longer and longer. But also, as you keep adding items, you may start asking questions that are actually tapping another concept. So it gets dangerous. It's a little tricky as you keep adding questions. Are you getting a better acuity of what you're measuring, or are you starting to dilute the measure out because some of your questions are going beyond what you're looking for? Reliability is necessary for validity, but it's not sufficient. So if you have low reliability, as that little graphic showed, your responses are all over the place. And what that means is when you start looking for correlations or associations with other factors, it means you may not find any strong correlation. It starts weakening those things. So the greater reliability you have, the more power. And so the better you measure, the smaller the sample size you may need to detect that something is associated with it. Keeping your instruments standardized or calibrate increases reliability because you have that consistency. As I indicated, adding items to a scale can increase reliability. Reliability is often found to become poor when you start dealing with lower literacy groups such as children, because there may be, especially when you're asking questions of them, whether it's reading problems or they just don't have the cognitive potential to understand, what are you trying to ask me? Or I don't even understand when you ask me, did I feel crabby today? What does that word mean? To a child, that word may mean different things. So reliability, when you have, it also happens with elderly. So I don't want to keep just picking on children. As we get older people, we don't always make the connections. So there are different types of validity. There's a content validity, which is more the experts say that, yeah, this scale that you have is assessing what you say it's assessing. There's a type of validity, criterion validity, which actually gauges the performance of the measure, whether it performs into the future or agrees with something else measured at the same time. So for example, if you're hiring somebody, I want a tool of how well they're going to maybe do on this job. And then a month later, you look at their job quality or whatever, if that would be predictive criterion validity. Or you can have concurrent, and that's whether you assess your tool with something else that's measured at this similar time period as the tool. And then you might also read about construct validity, and that's the extent to which it adheres to establish correlations with other theoretical concepts. So you can either have it convergent or discriminant. So a convergent validity would be, well, if I'm creating a scale to measure happiness, I would hope that it would maybe be highly correlated with life satisfaction. Because we feel, if somebody's satisfied with their life, they're probably happy. Now, divergent means there's going to be no or a weak correlation. So things like if I'm going after assessing somebody, how calm they are, well, if they're anxious, they're probably not calm. So I would hope if I would measure these two aspects, that they'd have a very weak or even no correlation. So validity has to do with interpreting the data. If your measure lacks validity, it may actually cause important outcomes to be missed. It limits your interpretability of the initiative. Certain tools, you have to be careful. They may be valid for only certain purposes. So if I have a tool that's measuring pain intensity, I shouldn't be using a pain management tool, okay? Pain intensity is measuring how much the pain is like hurting me, but pain management, no, that's going to go down a different angle of what am I doing to control my pain? Those are separate things. So you can't say, oh, look, they're in good pain management, so they should have a low pain intensity. Well, you can make that assumption, but you're not measuring it. So it's not a very good conclusion to kind of provide support. That would be something you'd want to maybe test. And as well as with particular sample, as I pointed out, with age or cognitive status. If you find a tool that was created for adults, be wary of just saying, oh, I can use this in my children. No, you can't, because of that cognitive things. So often certain aspects have age kind of appropriate tools. There's different ways to measure, especially things with a cognitive kind of things. Like people try to make like depression and anxiety tools for children, which are different from those tools used to assess that in adults. There's also something called cross-cultural validity. So like the promise measures I indicated, they have them in several different languages, certain aspects of them. They have had to go under scrutiny to show evidence that the original version, as well as the translated, as well as culturally adapted measure, are similar. So just translating a tool does not mean it's okay to use, because there's going to be certain, whether it is the term or even expressions or their cultural aspects that may need to be investigated as well. And then there's something called structural validity, which has more to do with factor analysis. And that's just identifying are the different dimensions within your scale, what you want them to be. I'm not going to go more in depth. So an illustrated example of some of what I'm talking about is for strep throat infection. So if you have documentation from a provider that, oh, they note that there's infection. Well, okay, the provider has education, and I'm assuming they're making their best clinical judgment. I'm not, don't go too wild on me, but it kind of lacks validity because they just noted that there's infection. Wouldn't you feel like it becomes a little bit of a stronger point that if there was documentation that not only do I have evidence that the provider document to say there's infection, but I also see some of the vital sign information. Oh, look, I see a temperature here, and that goes along, it supports it. And even better would be which is part of what the validity aspect that I'm going after, even a stronger measurement. Not only do I have the vital signs and all, but wait, there's a throat culture or strep test result there indicating, is it positive or negative? So that's what validity is trying to do. It's in the sense there's different levels of, if you just use the documentation that they have a strep throat infection, yes, no, when you run statistics with it, it doesn't maybe have the precision as it would be if I used actually, let's run people that actually are positive or negative based on the strep test. You may also be using diagnostic tools, and the validity reliability comes through more as sensitivity, specificity. So ideally a test would perfectly discriminate between those who had the disease from those who don't. So that's what this little sketch on the left kind of shows, that no overlapping. But not all diseases are like that, or not all tests can kind of have this clear distinction. Instead, there's more of an overlapping, like the picture on the right. And sometimes, depending on what you're assessing, it's a narrow overlap, but other times it's this wide one. So then you have to decide where to put cutoffs that define actually normal versus abnormal. And that determines like the sensitivity, which is the ability of the test to correctly identify those with the disease. So more or less who's the true positive, as well as the term specificity, which is the ability of the test to correctly identify those without the disease or the true negative. And then there's this trade-off between those two. Higher sensitivities will mean you have lower specificity and vice versa. So somebody, when they're developing either a lab test or even a scale, you have to kind of decide, where am I going to make the cutoff to say the people higher than this level are going to be, whether they go on to get further testing or whatever. Now, sensitivity and specificity alone can't actually be used to measure the performance of a test. The prevalence of the disease also becomes important. In diagnostic tests, the positive and negative predictive values are calculated, and they allow you actually to clinically say, is it more likely that patient has something of a specific disease, whatever you're going after. The high values reflect the accuracy of the test. In these, the figures right here, they actually show how prevalence influences the factor, because if there's a low prevalence, your test is kind of looking for these few people, like it's kind of like looking for a needle in a haystack. So you don't have a very high positive predictive value. You're going to get a lot of false positives, because it's maybe picking up other things than it should. So it just a feature. I guess why I'm bringing this up is something like a malaria test made in the US. If it hasn't been tested for a malaria test, like in your country where you have a higher prevalence, you have to take that into account, that they have different sensitivity and specificity features because of the different prevalence that we have in our communities. So an illustrative example is you, as a school nurse, you may document fever, headache, or muscle pain. The next step up for some kind of validity would be, a rapid diagnostic test. But even that rapid diagnostic test has some of that positive and negative prediction. And that's usually judged against what a gold standard, which is the blood smear, when they look for in the blood cells for the malaria. So again, each of these, there's different layers of like, how well do you believe in assessing what you are really assessing? So quick summary. Validity means the test is measuring what it's supposed to be. Reliability means it's going to give you similar results when you do it again. And the sensitivity and specificity together determine like your diagnostic power. And then the last part of these steps is—
Dr. Storr, sorry, before you continue, I got a question, and
okay.
If anyone else has a question, please, either type it in or you can ask it. So the question said, all this information is very helpful, but why would we want to collect data before making a decision? Say, for example, COVID, why is it important to collect data first before making a decision? And, just some contextual background to that is, we've sort of found different sort of information sources that we're relying on to make decisions, not necessarily based on actual data.
So I think in COVID, things were often decided without data only because of the seriousness and the speed of things happening. But usually actually the data was being collected. It just takes a little while to collect the data and also process it. So decisions based on data are probably stronger because you have then evidence of what's going on. I think under the COVID situation, leaders just had to make more instantaneous decisions, what they thought was best, and possibly, based on, scientific principles that they knew from other outbreaks and stuff. It was like, I think a lot was because of the seriousness and the speed of transmission that steps were taken. Like, it takes a while to set up your data collection team. What resources do they have to collect information? Again, even if you had a data collector in a little village or center here, what is happening in that little village might have been totally different from another village. So policies can't always be drawn by what's happening in one place and extrapolated to another. So having data on these different villages would actually add insight of, wow, maybe this one village really wasn't wearing masks or whatever too. So that's why the spread was more rapid versus the other village. Everybody stayed home. They didn't wear their mask, but everybody stayed in the house. They weren't adding to the spread. So understanding the data would help understand the differences to say what's going on. So I don't know if that answers the question of why data is important to base your decisions on.
Absolutely. I have a couple other short questions. You just talked about resources for data collection. So in a country that doesn't have an overabundance of funding, how much emphasis from a financial perspective should we place on funding research or data collection where, the funding could be put towards the solution instead? Like how do you sort of
but will you know that it's going to be the solution? You have no data to tell you if you made an impact or not. You may think it's the solution. There's many a times clinical trials where you think you're helping, the person has actually caused harm. So having data to actually evaluate, are you making a solution? Now, resources, I mean, that's where thinking through some of these steps. Do you have the best, you don't have to measure everything under the sun. You find one that's the best measure. Don't spend the resources on a poorly planned kind of project with weak data. That is a waste. So that's why we have systems of like the National Institute of Health. They have actually reviewers that review proposals that get high scrutiny before actually the money goes out to them. Because yes, every country actually tries to have control over their resources, but there are some data collection, depending on what you're doing, isn't very high cost. It may take cost of somebody monitoring, or a survey is usually not super costly. If you're doing diagnostic interviews, well, that might be because you've got to hire the professional to sit down to take the time to kind of go through the interview with the person. So there are different levels of where resources can come from. If you have your medical record data, sometimes you can glean the data off of records that already exist. So you're not really needing to apply resources to collect the data. Now then you're stuck with whatever data kind of they collect for you. It may not be the best measure, but sometimes you have to compromise in what you have and what you're collecting.
Wonderful. That was helpful. All right, we'll take two more questions and then you'll continue. I'm actually happy the questions are coming
Yeah.
in. And this is probably a low-hanging fruit for you, Dr. Storr. What is the difference between random error and a systematic error? And this is one our HFN nurse is asking, or nurse school lead nurse, actually.
Ironically, I had that in here and then took that out, kind of. Random error is more, like I said, are things that we can't control of. So there's always going to be some what we call like noise in the data. But since it's always there, you just hope it's just a small percentage. Whereas systematic error is going to create larger biases. For example, weighing children, a systematic bias could be whether, you didn't. So if you didn't calibrate your scale, everybody's weight's going to be off. Okay. So in a way, that is something you can control. But if different children are wearing different amounts of clothes, or one child didn't take their shoes, those sneakers are heavy versus somebody who has, just sandals on or whatever. That is a systematic, or like your protocol should kind of say, try to measure people in this same kind of situation.
All right, thank you. And so we'll take this one additional question, and then we'll let you continue. So in situations where there are no existing measurement tools for quantifying a particular abstract phenomenon, how does one go about developing one without losing validity? That's a very high level question. Thank you.
It's going to take years to do. How do you go about? Well, I guess you start with you yourself, like diagramming it. What are you trying to get? So you do this mind mapping, like kind of thing. What are the concepts that go with it? Deep dive into the literature. What are similar you may be surprised. A scale might exist out there. It's just called something else. That often happens. I see it a lot with our doctoral students. They think, oh, I'm the first one ever measuring this. And, oh, go deeper dive. Somebody in social work does the same concept. It just has a different label because it's a different discipline or something. But even if a tool isn't, but you can get ideas. So you start compiling what you think are, but then you start involving other experts. If you create a tool, you would ask other experts, can you assess this tool for me? What are their expert opinions? So that starts giving the content validity aspect of it, in the sense that other people also agree with you that they think it's tapping the right thing. And then you go through basically, establishing whether you can do the criterion validity or is it not like another concept? So you go through then those other validity kind of things. And as more people study it, the accumulation of the results in the data kind of start supporting that the tool that you created has some merit.
That was very helpful. Thank you. And I think that also then speaks to just fostering a culture, that believes in data collection and believes in outcomes and decision making based on data. Someone just put in a comment about how data silences people. That's one way to look at it, but in advanced areas around the world, data actually also then generates more conversation. So it could present as a pilot, to where it generates additional questions for research, or it either provides additional merit for pre-existing approach, or it shows us that what we've been doing has been wrong and there are other ways to do it. So.
Yeah, I think you're right. It silences the skeptics. Because like, no, I have kind of evidence here that something may be going on. Okay. Again, one study doesn't prove that, but and like you said, then it spurs the other people because they're curious. So what is going on? I either need to find evidence to challenge it, or I'm going to investigate it more to try to find a help to explain it. So that's where, especially national levels, we have it to, I mean, yeah, I know a lot of money is thrown into our statistics in the US as well. Like we have national health surveys of this and that, like just for monitoring purposes. Do we see trends that are people, okay, so again, I'm a drug use person. So I was like, yeah, is the use of alcohol in our country going up or down, or tobacco? That's a good example how years ago, the big effort to, because smoking is causing so many chronic illnesses, is behind it, so many chronic illnesses. Can we do prevention efforts to get people to stop smoking? So, well, one, we had to monitor, are people not, are people stopping, or also as well, can we show that children aren't starting to smoke? Let's nip it off in the bud before they even start smoking so they don't even have to stop. So somebody was out there collecting trend year by year, what the average school child, how many of them smoke or whatever. Do we see that decreasing because of policy that no longer sell cigarettes to children? There's no more advertising. They don't see smokers on advertisements and TV and those kind of things. And then as well, who's monitoring the outcomes? Well, do we see changes in lung cancer? Well, ironically, lung cancer also increased because people thought, oh, if you have lung cancer, you were a smoker. Well, there are other things that are causing lung cancer. But did we see changes in cardiovascular kind of issues? So you can do a lot with just monitoring trends of proportion of people having certain things or doing certain things. So any other questions, or should I just kind of, you were almost at my breaking point anyway, so it was kind of coincidence. All right, so
that's it for now.
Okay.
More questions will come in.
Okay, so we've been talking about kind of more the data collection, like the definition, what do we think we're collecting? But you also then need to project before you start collecting the data, what are you going to do with it for this analysis plan? Like what kind of data do you have? Some of it involves the studies design. As you'll see in a minute, I'm going to show if it's longitudinal, like if you assess something weekly or monthly or whatever, you can do certain things. Are you wanting to do statistical tests? So you actually have hypotheses that you will actually officially test, or do you want to have your analysis more from a visual point of view, which in nursing is a current kind of thing, which they're using quality improvement. So how do you select the right approach? So the most important clue is going to begin with what do you need to do? Is your purpose to describe something? Do you intend to explore differences? Do you want to quantify how things changed? Are you looking for correlations or associations? So is there a relationship between two quantities, or do you just want to picture how things might change over time? So then we got to start thinking about what are the type of variables you have and the number of variables. So if you're studying associations or whatever, you need at least two variables. So if you are just visualizing change of something, you only need one variable. But if you're comparing differences or looking at correlate, you at least need two variables, and that brings in, I wasn't going to go down that route, but independent and dependent variables. But but the type of variable becomes important. You may have heard of the levels of measurement, the nominal, ordinal, interval, and ratio. And these are important. Nominal variables are just like gender, male or female. It could also be, do you have the illness? Yes or no. Because they're category like that, it limits some of the type of statistics that you can do. Ordinal means, yeah, they're categorized like that, but there might be some ordering in it. And okay, sorry, this is my cultural bias. My example is kind of, hopefully you can associate with them, but I'm just like, we have grades of, some of our food is graded in order of, like, this is really prime meat, which, yeah, that's the most expensive. There are different levels of meat that you can get. So the quality of it is in this ordinal nature. Oh, wait, cancer, the rating of, what do you call it, stages, the stages of cancer would be kind of considered as ordinal, in the sense that if you have stage 4 cancer, you know it, when you hear that, you go, oh my God, how long do I have to live? So that is, could be thought of more as an ordinal kind of variable. Interval variables are, interval and ratio variables let you do a lot more statistics with them, because you have what are considered equal intervals between the concepts. So like the height of a person, a centimeter to a centimeter. So the average height of the girls in the class can be compared to the average height of males in the class, because height and even weight have equal intervals between the spaces. And then a ratio variable just means that there's like has a zero to it. But these higher levels of measurement, if your variables are of that type, it allows you to do more things with them. So, and that's what this slide summarizes. So to think ahead that the measurement is tied to stats, because if you're only going after descriptives, then you don't have to worry about it so much. But if you want to actually compare means and do things like that, you do want to get the right kind of variables, kind of metrics to be able to perform those kind of stats. You also need to think about how many groups you may have. If you have 2 groups, if you want to compare the means, you can do t-tests. But if you have more than 2 groups, so okay, male, females 2, but if you have, what do you have, 3? What's something that people would be 3 or 4? Even comparing different grades within the school. Well, that's more than just 2 grades. You would need to do another test called like a ANOVA. So depending on if you're testing for differences, how many groups you have is going to determine what stat you use. The type of study design and your constitution of your sample may also give point direction to what statistic you need to start thinking of. If you only have one time point, like a survey, you can't do so much like well, you can do t-tests and compare people within the survey, but if you have a pre and a post test, you can do a t-test that has that built in the before and after. Are your sample, are the people in your sample independent of each other? Or if you're doing this pre-post test, you have to do the correct t-test. There are 2 types of t-test. As well as sample size. is something to consider. If you have a large sample, you can do the more, what I'm going to call the more normal statistics, because they rely on a normal distribution. But if you have small samples, you have to start turning to non-parametric approaches, which aren't as powerful. So I wasn't going to go in depth in this, but there are schematics that help you and you may have somebody who can give you some statistical consulting too. If you're going down a statistical approach, how do I know what kind of test? Well, there's a set of tests that if you're comparing means or looking for differences, you go down this like right-hand side of this chart. If you have 2 time points, why did you move suddenly? You go down to a t-test. So are your samples independent of each other? Like I'm comparing males with females, they're independent of each other. I can do a normal independent t-test. But if I'm doing a pre and post kind of test, there I would need to do a paired t-test. But if I'm looking for testing a hypothesis that something should be correlated or there should be an association with something, then you go down, there's another set of statistics that are more on this green side of this graph, that where you can do chi-squares, logistic or linear regressions, correlations. So knowing what type of variable you have helps determine what statistical test you have. So for example, if I have a longitudinal study, I'm looking at the length of time in hours it took for a test result to be completed and come back. So I could capture change to say, you know, before I made this change, it took 8 hours. And this bar represents 8 hours for the pre-test. And then after I did some kind of intervention at, you know, several weeks later at a week 11, look, it decreased to 3 hours. I can actually do a t-test and determine, well, is that what we call statistically different to be able to say, my intervention seemed to work. But quality improvement is allowing us to say, wow, I can picture this, what's happening. This 8 and 3 though could happen in various ways. You could have like the top chart to say, oh, okay, intervention happened around week 7 and 8. So you have this graph of during the baseline, you know, it's going up and down, but you see at week 4 is my 8. After my intervention, look, this intervention actually did something. And the graphing of this week by week actually shows that whatever intervention you did week 7 made a change. Whereas the second graph, yeah, week 4 has that 8 and week 11 has that 3. But when you look at this graphic, before or after, there's no difference. Whatever this intervention was, it really did not change anything. So the statistical tests of, yeah, there's difference in week 4 and 11 is kind of hiding the real picture. Whereas, okay, and the bottom graph actually shows, okay, it looks again like the intervention made an effect, but after week 11, what's happening is it's probably behavior went back to normal and it rose again. So this could mean the intervention had like a temporary, immediate effect, but then whether something else changed or people, oh, I don't like doing all this, or I went back to my old ways, and you can see it wasn't a long-lasting change. So whether you as an intervention person would come in and do another intervention there to kind of keep it back down again or whatever. But the thing I wanted to point out is statistics can do this comparison between week 4 and 11, but sometimes maybe having this visual of what's really going on is really what you're after. So if you want to evaluate the impact of change, it's important to see that variation. So doing statistics, descriptive, the means, the modes and all is kind of a static, whereas I'm going to introduce you to a run chart. which is more or less a dynamic view. You get quick results and you see it happening almost, over time. So you can also do, before we get to the run chart, you can kind of visualize it using box and whisker plots. And if you don't remember what a box and whisker plot is, it's kind of like taking the distribution of the result of your data and tipping it over to a side to say, oh, look, I have a median and I have the highest value, the lowest value, and you make, here's your little box, and these little tail things are what are called the whiskers. So you collected it on Monday, oh, here's the distribution of the data, then on Tuesday. So this is a plot of 1 week's worth of values, and you kind of see on Friday, the values have kind of shifted up a little. So that's what caused that? Did you do an intervention? What's going on? So, but is a visualization of what's happening day to day. In the US, some of the the electronic health records are now into doing like these dashboard kind of things. They are trying to give you the same kind of picture of what's happening on a daily or week, sometimes it's weekly data. Like this was an effort for ER wait times, in a sense of trying to lower the minutes, so they could plot to see, maybe to say, oh my goodness, on weekends there's longer wait times. Why? Do we need to change our staffing or whatever? But they're starting, visualizing the data, what's happening. Run charts is another way to visualize this data. So here was percent of patients roomed within 15 minutes of arrival in a clinic. So these first couple months, this is what their normal rate was, about 30 or 40% of people. But then April says project initiated. So sometime in May, June, they did some kind of a self-serve registration. So you can see the wait time, more people got into the clinic faster. This is what it's plotting. These are what a run chart can show you. So here's a 1 year's worth of doing different things to try to make a change. So that's where I was going to stop and ask questions, but did any more come up? Otherwise, I'll continue.
To sort of relate this to what we do, I guess another good example is one of Health for Nigeria's initiatives is the Nurse to School initiative. And our goal is to try to keep students in rural public schools healthy. So we refurbish spaces in rural public schools. We, place clinics, or, we remodel, bring in healthcare equipment. We hire a registered nurse and we place the nurse in those clinics. And our goal is that students' health would be improved. Students would also get information, to health promotion, disease prevention at an early age, and that should impact their learning. So I guess, your April project initiation could be when we start our Nurse to School program. Our goal is to actually collect data over time to demonstrate impact of our program, so this presentation is not only timely for us as a nation, but I think also as an organization, this is what we plan to do.
So let me show you some of the basic components of creating something like this, because I think it's very straightforward to do. So you can actually collect some percentages of something you want to assess. You're going to create like your goal, and well, I'll go over different parts. So what is a run chart? So essentially a run chart is just a line graph that's going to show your data points over time. And then that's going to allow you to see changes, these signals of improvement, or the process went wrong or something. So it's just a graphic of depicting whether improvement has occurred. And then we're going to look for, I'm going to show you what some of the signs, what we look for are shifts and trends. It doesn't have control limits. That's another level of quality improvement. A run chart's like the basic one, and makes sense. That's where we can start with that. So what you have is a y-axis. Sorry, this graphic's not as clear, but I wanted to show different pictures of them. So you have a y-axis, which is actually your outcome of interest and percents of whatever you want to study. I mean, it can be other things besides percent, but often it's an easy percent. It's an easy one to start with. You have an x-axis, which is your time element. So whether that represents minutes, hours, days, months, years, whatever your time interval will be. And some of that depends on what you're assessing. Certain things don't change in a minute. So you have a longer time period. You're going to have some kind of baseline data as well as future data. Why you need baseline data is because you need to establish where are you before you do anything, okay? And from that baseline data, you determine what is the median or the mean of your baseline data to say, this is where I'm starting. So in this graphic, it's this faint little red line here to say, whoa, before I do any kind of changes, we're at this percent. And then your run chart usually has like a goal. Where am I going? A lot of times people don't aim for 100%, but at least, you know, maybe 90% or whatever you think is achievable, like to say, yes, I got up to my goal or not. So the best practice, though, make sure the data is accurate, collected the same way, all those quality measure kind of things I had mentioned earlier. And you want to maybe make the chart as close to real time as possible. Don't let the data just sit there for over time. So when you create a chart, like you have your appropriate scale in the sense of your percentages, you have your time elements again here, your center line or baseline kind of thing is marked here, your target line. A good graph also has the name of the measure on it, as well as if you want to put like hints on what's happening in the graph as you go. So for instance, this is marked pre-implementation. So between, now I don't, whether these are weeks or days, that would have been nice to have marked on the chart too, but it doesn't. So let's say it's days. From day 1 to day 12, this was their baseline. And you can see even there it goes, you know, up and down, but you calculate your median. Why their baseline in this picture goes up is because they calculated a new baseline after the intervention to kind of also highlight, look, it changed from about 25%. It went up to whatever this would be, let's say 60%. And then they marked week day 13 to 31 as post implementation. And they marked down here what they actually did as part of the effort to make this change. What may have caused or well, it's not causal per se. Well, I have to use causal carefully in my language, but what might have triggered the change. So sometimes it looks like this first effort they did at day 14, and it doesn't look like a whole lot changed, right? Between 14 and 17, it looks like it's still just like it was at baseline. But whatever they did here after like 18 down there we start to seem like, wow, things have moved on up. So this is kind of maybe explaining, pointing out which of their interventions might be driving the change. So I needed to talk about the variation because that's what we're going to look for. So which I guess goes a little bit also back to the previous question about the error. It's very similar. We talk about common cause variation, and that's just random. So day to day, data will have some movement. It shouldn't be flat. It should have a little movement. And that's just due to ordinary changes. It's part of a stable process. But when you have non-random variation, like this chart here, like after week 18, there's something going on here because you see this like shift suddenly, like this right-hand side of this chart has moved, kind of taken a jump up, which is good because that's what you were aiming to get toward that goal. That is kind of a picture of non-random variation. It's due to something irregular or unnatural that wasn't part of the normal process. And in this case, in this chart, it was, well, yeah, it was due to one of these intervention efforts. It was unnatural. Somebody came in and wanted to change the process. And then we saw a change. So that is basically saying, okay, it's an unstable process, but that's good because we wanted to upset the process with the new thing, whatever we were trying. So when you plot these patterns, there's actually 4 like rules that would determine if there's something going on. I'm only going to cover the first 2 rules because they're the easiest one to apply. And that's, we look for these shifts, and that means there's like 5 or 6, depends on when you look in the literature, people use different numbers of these things, but there's a pattern of things, of points above or below the median. Like there's a shift that moved everybody up, or a shift that everybody's below what the median line was. And or you can also see trends where there's 5 or 6 points more in a row that are always going ascending, or number of points descending. And so these are things kind of saying there's something going on that made a change, and you should try to investigate what may be triggering that change. So here, just another graphic is the shift is 6 consecutive points above or below the median line. And that means a special cause has occurred. If you see a trend, 5 or more consecutively going up or below, or going descending. Here's an example actually from an article. This was their main outcome. They were looking at oxygen delivery to patient at the bedside. Is it consistent with the order and the range in the chart? You can see the baseline is 20%. So they start educational messages, and you can kind of see the poster didn't really do anything. They collected data. So the time point is weekly. So here, week 1 through 6 is basically the baseline. They posters and even the education message didn't really do anything. But then they started another initiative of more emails, personal emails directly to people. You saw maybe, whether this is an increase, I don't know really, because it's not that much higher than the baseline. But as you see, week 8, after week 8 and on, so something when they started to do a pharmacy review, as well as writing the oxygen saturations on the whiteboard above the bedside, there's where they start seeing, oh my goodness, there's more compliance. People are doing what we wanted to do. So this plotted out the weekly efforts to have the change occur. So strategies for a successful measurement. you got to be clear on your purpose, define what will be measured, make sure it's focused, know your data sources, where's it going to come from, how will the measurements be collected. I would advise using a standardized tool and a standardized method. Who's collecting data, make sure they're trained right, everybody's following the same procedures, know how often it needs to be collected, and then think about how the data is going to be used, whether you're going to display or analyze it. And I'm proposing you kind of think about possibly using a run chart. I guess I can talk. I know I talked with Bim a little bit beforehand. You're doing some kind of effort of hand washing. So you could possibly think about making a run chart that whether you want to take a random sample of kids every day, how many kids do you observe washing their hands? So you know how many kids you have in school. So you saw 10 out of, I don't know how many are normally within your school system. I'm just going to take I'm going to use 100 because that's an easy number. If you have 100, you have 100 kids and you saw 10 on day one wash their hands, whether you do it daily or once a week or whatever. The next time you saw 15, you start plotting 10%, 15%. So you establish a baseline, and then maybe you have an initiative of what did I do? Did I do a fun activity or I set up I don't know, I put something by the wash basin that made it attractive for the kids to come. And wow, now I see 40% of the kids come. You can actually plot this out to say, and you could write down, what did I do that day or that week to say what encouraged kids to did it work? You could actually plot out to see, are any of those initiatives making a change? So I'll stop there and ask for any questions.
So there's a question, in terms of the run chart, other than what you've presented, is there any other necessary training one needs to have before conducting this?
The run chart, probably not. I mean, at some point for initial efforts, it's just a percentage. You define clearly what you're going to observe or count. What is your measure? What are you focusing on? You need to know what your sample base is so that you can calculate your percentages, but it's pretty straightforward. And then decide your time points and you just plot it out. So it's not like this run chart needs any special training. Now, if you start going into some of the other quality improvement things, yeah, there it gets a little bit more special training. But the run charts, there's a lot of, you can read about a lot of it about it if you do a Google search. There's some intros about how to do it. I think you're thinking of the higher level statistical process control measures, which are similar to run charts, but they need special training. They actually call them like black belts, and yeah, they have different levels.
Okay.
Sorry. I had a question if it's okay to take it real quick. So I guess in a program like ours, where there's limited baseline data, or at least data before we started working with the schools, how do we, is a run chart still something you can use to maybe show impact, at least some level of growth from when you started to where you are right now? Or is there another tool that you recommend to use in that kind of situation? That's, I think, similarly as not as complex, but because I think the run chart looks fairly simple from your explanation, but is there any other tool of that same level of complexity that can be used, or do you think a run chart is still sufficient at that point?
Well, you can do the run chart, but you can also do then the stat kind of, you can actually do the t-test, like you pick a point, kind of like my illustration, how it had the week of 4 and 11 or whatever week it was, 8 or 11, whatever. So the run chart just shows you how it is stable across the time, but then you can actually do a statistical analysis to kind of, if your chart went up like that, well, then you can feel confident in doing that statistical test and saying, look, it statistically made a change.
Yeah.
But if your chart kind of was all, up and then, oh, there's a statistical change, but no, because my chart kind of says it's not. So you can use the both together. And yeah, if you have baseline already data like in the records, yeah, you could plot that. But I guess usually it's thought of as, yeah, I see no problem with it. Or you start, well, it just shortens the time. As long as you have the data in your records to be able to do it, it should work.
Thank you.
So usually with these presentations, we like our presenters to leave us with a charge, and it could be 3 things, it could be 5 things, but, based on this new knowledge, everyone should do A, B, and C, and our goal is to build a culture of, not just data collection or analysis, but understanding where data stands in the decision-making process.
So that's where I think also from a decision-making point of view, even the visual things like the run chart, it isn't hard to understand when you see it. You see this pattern, you go, wow, weekly something's changing, or like, people have learned, well, most people have learned to read a simple, it's a pretty straightforward line chart. It's almost powerful to see, how did if it's staying flat, we need to do something time after time, nothing is changing. Like that's evidence right there to say nothing's changing. Or whatever you're giving us to do, resources or whatever, look, it's not doing anything. There's evidence that nothing's changed. So that sends a message too, versus, okay, now I have a chart that whatever I did, I showed a change. Of course, that one you're proud to show off, but a chart that shows no change is just as enlightening to say, wait, you're having me waste resources and nothing's happening here. Now, again, it's just on that one measure, it may be impacting other things you didn't, collect measures. So don't throw what we say, the baby out with the bathwater. Maybe, whatever you're doing is important for some other aspect, just because it didn't impact the one thing you're assessing. Don't be too quickly to drop your program. But I think from a point of view, we often have that as researchers when you want to try to change the minds of physicians. They're clinically orientated. Yes, a lot of them have research backgrounds, but not, it's not a high number. They don't understand statistics, but sometimes we just say a table or a graphic, that picture is worth 1,000 words. So that's why, yeah, you're saying, oh, this looks too simple, but it's not. It's still presenting data in the proper way, and you can back it up with, like I said, with a statistical test there. Now it doesn't. there's going to be some proper things too, that you collected your data correct. Like, who is your sample? Did you pay attention to your sample? Like, if your sample is only 5 people, plotting percent changes on 5 people, one change jumps it a lot, you know what I mean? Whereas if it's a substantial sample size, and I'm not going to say what a magic number is. I mean, for normality, for when I talked about parametric and non-parametric statistical tests, we usually use kind of a sample of around 30 or more would be okay to start running t-test. If it's less than 30, you probably don't have your normal distribution. So it's kind of considered a little bit more like a small sample. So I don't know what is the average class size, or the number of children that are coming to average school that you're working with? Is it over 30, or I don't know all that. So that's where that would, I guess, be a factor.
Yeah, each school has several hundred students, you know.
Oh, but then, okay.
Yeah, so.
Because you could always combine grades.
Mhm.
Like if you only have 30 children well, we go by grades, you may not. I was an exchange student one year and they didn't use grades. So whatever levels or whatever. So if there are not enough children in level 2, well, combine them with level 3 or whatever, and that would increase the sample size for that similar age group.
Wonderful. That's very helpful. Are there any additional questions? Any thoughts, you know, about what we can measure and how we would like to go about it? I think a hot button topic for us is COVID-19 and the fact that we don't have a very high number of positive cases. You know, we should also mention that we don't do a lot of testing. You know, so I mean, it's really hard to then present, you know, the impact of COVID in a country like Nigeria. But some of the arguments that I've had, you know, with some of my colleagues is that our mortality rate has not increased significantly. You know, so is that a good way to sort of measure when dealing with data? Because now we don't necessarily have measurement data, you know, but is that a good way to you know, sort of make some concrete statements about where we are as a country, Nigeria, you know, in terms of COVID?
Well, what's happening is you are turning to what I would consider like proxy measure, like you're using other measures that you are not just assuming we know should be correlated. I mean, if you had if there was widespread of COVID and really maybe have a strain that's maybe not as deadly or whatever, again, from the rest of the world, it's saying, wait, it's correlated with increases in deaths. But if your death's not increasing, we have the other thing. People are saying, wait, those deaths aren't all COVID. Some of them are naturally occurring and they're being counted as COVID, which isn't correct. We have a lot of political, how is our death rate even attributed to COVID really being counted correctly as well? So we're using those as kind of proxy measures too, actually. Because even testing people as a COVID in their blood or not, is that actually correct? Because maybe it has always been there before. I don't know if anybody's done study. I don't know if people have pulled frozen blood out, or it could have been in us previously. It just something triggered to make it active. Like, so even the tests that are detecting antibody in people, is this a new thing or it's always been there? So I don't know if all that has totally been figured out. I'm trying not to read all that COVID news. It gets depressing.
That's very helpful. We have a question from one of our board members, Dr. Lupeju.
Yeah, good morning. to the doctor. I really enjoyed this topic, even
Thank
though it's a
you.
little, it's kind of complicated. I remember doing statistics when I was doing my master's program. I just want to piggyback on the question that Dr. Akintade just asked about the COVID and the use of statistics, data collection, statistical analysis, and implementation. My question is, do you encourage data collection, statistical analysis, where there's no implementation? In the culture where we are in Africa, is it useful to do statistical analysis, data collection, when there's not going to be any follow through or implementation of the outcome? For example, in Africa, our governments don't really use this to do anything. So do you encourage to spend money to do all this, and then when there's not going to be any action from the government or the powers that be, what would be the usefulness of the effort if there's not going to be any implementation or action from the government? So that's my question to you.
From the national perspective, our country, like I said, it collects national measures too and doesn't really do any implementation on a lot of things. I mean, we have a national survey of drug and alcohol. What are they doing to really, okay, yes, they're using money for research to try to find prevention efforts or whatever, but you could say in a way they're not. So I guess the purpose of the data would still be used more for monitoring. Some of it might also be politically that we don't totally understand. Some of it may be money, whether from the WHO. It also needs, it tries to do some global monitoring. Like, what if we don't know what rate XYZ's in your country of this, and like here, like a COVID outbreak came, it's like it's a missing hole in the international picture of something. So having base, data on certain things is important so that we can have the global awareness of what's happening. But yeah, if they're just, I mean, we have all those, like I said, we have all those surveys too that are just counts of things to be able up at a national level. Some of it goes into bed planning and stuff that we may not understand the purpose, but if there's this estimated number of obesity or this number of immunized people or whatever, we can project down in years to come, as people get older, they're going to need more potential bed space, or sometimes they're projecting things that we may not even totally know what they're used for. Like the count of how many people have like malaria. I mean, okay, probably that after a while they need to know, aware of, yeah, if there was, that you can do some service planning around just knowing the counts of certain things.
Well, how do you train statisticians that can do those kind of work? For example, in Africa, we don't have experts like you, or even people who have been trained to become somebody like you. So, for example, for this ongoing pandemic, all we hear is that we don't have that many COVID in Nigeria or in Africa. When there's no data to really back that up, people are dying every day. We don't know where they're dying from. So, and the government is spending money to buy masks or to vaccinate people, without any proven statistics. So that's my whole point, that I know what you mean. You collect data, it can be useful in the future, but when there's no concerted effort, to use those data, what is the usefulness of that? But I do agree with you that you have to just do what you have to do, collect the data. It can be useful in the future for comparison sake, or maybe somebody will come in the future that will actually use those data for and implement action, So it's a tough one. In the US here, at least, even though we collect data all the time, we still see a whole lot of action, and implementation, But it's, where we come from is just basically, anything goes. So you have to do what you have to do, I guess.
Yeah, I guess it's more or less, it may be harder to work from a national level versus trying to can I get from my particular community or my kind of whatever geographical kind of entity, can I do some monitoring efforts and some basic try out some things, and then possibly especially if you make successful changes that could catch the eyes of other geographical regions of what did you do there? Maybe we need to monitor this in our thing too. Maybe sometimes things don't start from the top down. Maybe it's a effort of a community, others get kind of see how it could happen and then they start. I'm just thinking of, because we have that, California often is very progressive in trying to change health behaviors and stuff. So a lot of public health efforts come out of, they have big pushes of how people can control their diet and stuff like that. And then once people saw, oh my God, you can impact this by, let's say, the number of grocery stores or there's certain factors that from an environment, a structural point of view that can be changed, that, wow, this can be done in another community because it's a matter of, wait, do we have enough resources in a sense of, if I'm trying to change the dietary thing, what am I doing to change the food chain or whatever? So it could be starting out at one geographic kind of data from one area to show there's evidence of this happening. And then you just have to assume the rest of the country's similar and go from there.
So we have another hand up. Estelle, you have a question or comment?
Yeah, hi. Good afternoon, everyone. Thank you for a very insightful talk and discussions. I just wanted to comment and just pardon me to sort of, should I say, counter some of the points that was raised by the last speaker from the board, or give an update on some of the activities happening in Nigeria and across the region. I think it's very true. There's a lot of work still to be done in this space. We have a lot of work to be done. We recently, as my organization, Disability Solutions, we just last week, a week today exactly, hosted a Data for Health thought leadership event, where the theme was data for decision making, precision medicine, and impact and social impact. And what we did, it was like about a 5-6 hour event. We brought a whole host of stakeholders in the healthcare space, from government to private sector to funders to even at the state level, some people from the state level, discussing how data is used for improving healthcare and, discussing the gaps, discussing the issues around governance, the issues around data ownership, the issues around access to data, the issues around utilization, and that capacity. So I would just like to add that we have data. Nigeria is sitting on big data across so many sectors of the health space. We have multiple stakeholders working in that space. We have, projections. If we take COVID, for example, we had projections of, the deaths and what was projected to happen in Africa, millions and millions of deaths. But because we're collecting our data and really using it to really inform our narrative and, using it for decision making, we found that there was sort of strength in approach from different countries, loads of lessons to be learned, loads of lessons to be even exported to different climes in terms of what was done in the response. I think there was a lot of expectations that things were going to go not so good. But, it's not perfect. There are definitely gaps, and there's definitely a lot of lessons to be learned. But I just want to say we have a huge human capacity opportunity in Africa. Approximately about 60% approximately of the population is under 25. And there's a lot of work happening, not just in health, but in the data space generally. There's a lot of interest with that kind of roles, data analyst, data scientist, the fintech space, and this is all going to contribute to what we do with big data in the healthcare space. So I just wanted to say that, we're definitely not where we want to be. The event we had last week brought up a lot of very real conversation. Like I said, it was a thought leadership event, and it was really to bring the real hard truths into what is happening, where the gaps are, where the challenges are, and also to share some great lessons of good work that people are doing across the region, across the country. And I come to this from someone that has worked, in different climes, but also worked in Nigeria from the federal perspective. And I was also an advisor to a state government on health. So I've seen it from the state level and the federal level. And there's a lot of work to be done. But I think opportunities like this, where we're having such discussions in a coordinated way, bring in, and this is the first time I've learned about this organization, Health for Nigeria, and I'm really excited to hear more about the work they're doing. So it's really about coordinating the approach, being focused on ownership of our data, being focused on how our data is used for impact and how our data is used for really decision making to really address our unique challenges, and then building the capacity in country and across the region to really be able to have a sustainable approach to how data is used and how data and the expertise for using data. Thank you so much.
Thank you.
Awesome, thank you for that. That was very very helpful. So it's 10:30, and I would like to be respectful of our time. Dr. Storr, thank you so much once again for taking the opportunity to give us this really high level presentation and also answer questions. Really appreciate it, and I'm hoping this was an opportunity for all of us to sort of take a step back, think about additional data we can collect, or to start looking at how we can access the data we already have to make additional decisions. So thank you so much for your presentation, and I'd like to thank everyone for taking the time to join us for this presentation. We genuinely appreciate it. Thank you very much for the questions and the comments, and Health for Nigeria looks forward to opportunities to continue to partner and to also listen to imaginative ideas you may have for how we can continue to support the healthcare sector. So thank you very much, everyone.
Thank you.
All right, and just to close us out, I'd just like to say, as Dr. Akintade said, thank you again to everyone. If you have any further questions or comments, or you want to find out more about data and reach out to Dr. Carla Storr, you can always send us an email. I'll put my email address in the chat, but everyone here should have also received an email message to confirm attendance of this lecture. So please feel free to reach out. You can find us on our website as well at healthfornigeria.org. And I think on behalf of the entire organization, I'd just like to say thank you to everybody that showed up. Thank you to our board of directors, our board of advisors, and a very huge thank you, Dr. Carla Storr. This was extremely high level, and I'm sure there might be a lot of follow-up as to what people might want to learn more. So we really appreciate everybody's time, and pray you all have a good day and a blessed day too. So thank you so much.
A nation with a population of over 200 million people, with only 35,000 doctors. That is one doctor to 53,000 Nigerians. The healthcare allocation is 3.5% of the GDP, $5 per person per year. WHO recommends 5%. This explains why our healthcare system is the way it is. Patients are not being attended to. Government hospitals are overcrowded. Health workers are overwhelmed. Private specialists are unaffordable. Something has to be done. To tackle these issues, Health for Nigeria believes the healthcare sector needs an inspired and well-motivated group of young leaders to canvass and act for excellence in the healthcare standards of Nigeria. Our team of healthcare professionals and leaders are committed to improving access to healthcare. Nigeria, a nation with a population of over 200 million people, with only 35,000 doctors. That is one doctor to 53,000 Nigerians. The healthcare allocation is 3.5% of the GDP, $5 per person per year. WHO recommends 5%. This explains why our healthcare system is the way it is. Patients are not being attended to. Government hospitals are overcrowded. Health workers are overwhelmed. Private specialists are unaffordable. Something has to be done. To tackle these issues, Health for Nigeria believes the healthcare sector needs an inspired and well-motivated group of young leaders to canvass and act for excellence in the healthcare standards of Nigeria. Our team of healthcare professionals and leaders are committed to improving access to healthcare for all Nigerians, especially our children. With our nurses in all basic schools in Nigeria, we give children basic health education and support across Nigeria. Health for Nigeria, health equity for all Nigerians.
All right, thank you, everybody. I think we'll go ahead and close the meeting now. Thank you for your time and have a good day.